It looks like Bishop Nicholas has joined, and Sayedna, I want to ask for your blessing to continue as moderator for this event. And if you can unmute, again, I ask for your blessing, Sayedna.
Sure, absolutely, Michael. God bless you. We need you to moderate the question and answers and send them to the right physician, or all of them are right physicians, but to the specialty of the physician. And the others can chime in as well. And we thank them so much for taking the time to answer questions of DOMSE parishioners. So God bless you and be with you. And we are praying for you as first responders, so that you are kept away from the coronavirus.
Wonderful. Thank you, Sayedna, for the blessing. I want to check to make sure we have all of our medical staff on, and I can introduce each of them. I see Dr. Sergey. So Dr. Sergey, if you could make sure your video is on, and I'll have you introduce yourself to start.
Hello, Sergey Akimov. I practice infectious disease in Naples, Florida. Graduated Rush University in Chicago fellowship back in 2007, and I've been involved with the coronavirus response at my local level. So thank you for having me.
Thank you, Dr. Sergey, very much for being on. Okay, how about Dr. Fadi? Have you joined?
Okay. Hello, Michael. You hear me? Okay.
Yes. Hello, Doctor. How are you, Dr. Fadi?
Good. How are you?
Good.
I just found out. I was watching you and I said hello to Sayedna, but then I found out that on my laptop on the desk doesn't have a camera. So
that's okay. Dr. Fadi, we just started. If you wouldn't mind introducing yourself and tell everyone again your field, please.
Yeah, Fadi Malek here. I'm a pulmonologist, lung doctor, and sleep doctor, among other things. So, and I'm here in Lafayette, Louisiana. I've been here in practice in Louisiana more than 20 years, probably.
Wonderful. Okay, we have 2 of the 4 on so far. The other 2, I know everyone's very busy, and especially in the medical field, emergencies can pop up. So we'll start with you, Dr. Fadi, and also with Dr. Sergey, since the both of you are on. Jessica and Dr. Gregory, if you've joined, please let us know you're on. And I'll also send them a message to let us know and to unmute as soon as they do join us. But we'll go ahead and get started here with this panel with the 2 doctors that have joined so far.
Yeah, hi, everybody. Hello, Dr. Sergey. I think Jessica.
Hello, Fadi.
Hey, how are you? I think Jessica just texted that she's 5 minutes late. So.
Okay, no problem. We'll see her when she joins, and we'll go ahead and get started.
So when was our first meeting? Almost a month ago?
It was, yeah, it was a few weeks ago. Yeah, I think it was almost a month ago. So this is now the second of our question and answer sessions. I want to thank you both doctors very much for being here and for being available to answer these questions a second time. A lot of things have happened in the last few weeks, so I'm sure there are probably a lot of updates that we can speak to with the different questions that come in. Now, I want to ask everyone to make sure that you please put your questions in the chat feature. I see that some of them have already started to come in. That'd be the easiest way to submit your question. If you can't find the chat feature, or if it's not easy for you to do that, feel free to unmute at a time when we've paused to ask your question. But I'm going to go ahead and start with the first questions that have already started to come in. The first question is from Sarah Hodges. And it says, the test for coronavirus sounds awful, like a biopsy of the medulla oblongata. Is there a less invasive test available? Dr. Sergey, if you would, I'll start with you, please.
It's pretty easy test. The swab goes into the nasopharynx through the nose. It helps when the patient tilts their head back and the swab goes right through. Most of the time, unless there's a significantly deviated nasal septum, it will go right through to the back of the throat. It may tickle, it may cause a cough reflex, but it's not painful at all. Swab is really thin. The person who will collect the swab will keep it in there for 2-3 seconds. Sometimes they rotate. Sometimes they rotate when they take it out, but it's nothing like a biopsy. It's a really easy thing to do. They do it from the car. I mean, you could some of the drive-through, you just open your car and you sit there, and then they swab you right from your car seat.
Dr. Fadi, I don't know if you would have anything to add on that.
Or what I can add that I've never heard of a medulla oblongata biopsy. I don't think you will be talking afterwards, but that's a good thought. The picture of imagining that what the TV has been putting on, and some of those medical correspondents trying to illustrate, does look like you're digging deep, almost reaching the medulla. But like Dr. Sergey described it, it's probably pretty much the TVs have been covering most of that. You know, the screening part varies from one region to another. Some of it is not as invasive with a brushing end to the tip of it. A month ago, when we did that first session, we were like hands-on, trying to find out or learn. And since then, the testing has come along a good way again from one region to another. Like I can speak of our hospital area. They started to have the in-hospital testing taking a 1 hour, that in the emergency room, at least they are getting the answer instead of the 7 days that it was taking. But that doesn't take away the discussion, what kind of testing is optimum, what testing is giving us the right answer, all of those technicalities that probably all the audience and ourselves are trying to understand in what traditionally would be a more calm situation where medicine and science advances, and that usually takes time. We are doing it and learning a brand new disease, basically, hands-on. And if anybody can disagree with that, maybe the time can tell later on. In the medical circles and in the medical societies, what are we basically going to describe this disease as? Right now, it's surviving and in the line of fire, from the testing to the treatment to the disease description itself, because we're, I think, discovering more and more the other organs besides the lung that it could involve. And I'm glad I think we have a neurologist on the panel. Maybe he can enlighten us a little bit about it, because I'm discovering that those who survive from it, it is affecting their mental function in a, what we call it, an encephalopathy type of a thing. Again, this is all observational, and as a scientist and doctor, having practiced or trained to practice in the evidence-based type of a medical world, I don't think I'm at the stage to say this is it and no other way. The book is open, and I think we're gonna evolve with it by the time this storm settles down.
Thank you, Doctor. It looks like Jessica has joined us. And Jessica, if you wouldn't mind just introducing yourself again to everyone.
Hi, everyone. My name's Jessica Tarabay. I'm an infection preventionist here at Emory University Hospital. So definitely have been tackling this from a different side, working with our front line. So it's been very interesting, to say the least.
Thank you, Jessica. And the question we were just having Dr. Sergey and Dr. Fadi answer was the question about the test for the coronavirus. And some might think that it sounds like an awful procedure. And is there a less invasive test available? Anything that you might want to add to that?
So yes, I have definitely heard as well. It's not the most pleasant. There have been descriptions. It feels like, you know, you have to go very deep to get a good collection. And so other methods that we've, you know, been considering there, and it's basically up to the determination of each place's lab. So in the hospital, we have different, you know, different methods that we can use. I believe there's a saliva test that can work. Also, there's a nasal turbonil or so. That's another option. And then to get more invasive collections, that would be from like a bronch or something like that. So different methods, but now we're starting to utilize serology tests a little bit more. So that's just in that it's not going to show active infection, but it may show if you've been exposed or have had the virus in the past.
Thank you, Jessica. I'm going to move to the next question in chat. Again, if you do have questions, please use the chat feature to put those in there. You can also unmute if you're having trouble with the chat, but let's move on to the next one. This next one comes from, looks like Al Lipscomb. And it says, I've seen a lot of comments on the percentages related to catching the virus, the percentage of people who recover, etc. The message is that there is just a tiny risk relating to this virus. How would you characterize the actual risk of this virus to the population as a whole? Dr. Sergey, would you mind starting with your response, please?
So the spectrum of manifestations varies from lack of symptoms completely and never becoming ill to being really sick and being on mechanical ventilation. Majority of on the grand scheme of things, 20% so far that we know of patients will require hospitalization. So 80% will be not sick enough to be in a hospital. This percentage may actually increase as we learn more about population that has no symptoms at all. Because as you understand, you would not know who is sick if they have no symptoms. So we will gather more information as we will have more population-based studies based on those serologies. But most people will not be sick enough to be in a hospital and probably will have more mild illness. As the older the patients are, illness will maybe more severe and leading to more severe pneumonia and hospitalization. So I don't think we know risk of acquisition. I mean, we know that epidemiologically, one sick person, if you don't do social distancing, will infect 2.5 to 2 to 3 people. So that's how it will spread. So it's relatively infectious. But again, a lot of these people who will get infected, they may not be sick enough. So you will not really recognize those cases.
Thank you, Doctor. Jessica, I'm going to go back to you on this, if there's anything that you'd like to add.
No, that's pretty spot on. As far as, I think, you know, in the beginning, we were comparing this to the flu, to where there's typically like a 1% hospitalization rate, to this, which has been around 18 to 20% of hospitalization for COVID positive patients. So I definitely agree with Dr. Sergey on this.
Great, thank you, Jessica. And Dr. Fadi, do you have anything to add?
Not much, I guess, again, compared to what we tried to hash out in the first meeting when I go back to that, trying to remember what we talked about it. You know, the numbers back then were like 85%, nothing happens. You got the 15%, 10 or so of which may go to the hospital and come out of it, and then the 5% that they can get sick, and the 1%. All of those fudge factors or fudge numbers, I think we were trying to compare to the flu, as Jessica said, and that's probably more in their realm of expertise, both Sergey and her, from a public health standpoint. I think the bottom line remains, and correct me if I'm wrong, Jessica, is the denominator. The denominator is knowing the number of cases, which it's impossible to test the whole population of 350 million. With flu, you have developed year after year penetrance. I think you've been hearing all the experts. Those terms are probably now lay terms that we can use it. But in public health, there is the penetrance, if you want to follow a certain disease to see how spread around in the population. because of that asymptomatic, the non-symptomatic carriers. I mean, which we don't know, as Sergey mentioned, but maybe Jessica can fill us some more as to Atlanta. What are these serologic testing? Because, between what is true science and laboratory and what is political debate about it, we kind of give up on following. So each area is following its own ways of testing, etc. I don't think in my area here in Louisiana we reached the serologic part, but that's where it will tell if you've been exposed to it, and you say, well, I was never sick. This means you were that asymptomatic carrier, that you were exposed to it. You are immune with your antibodies, but you were never sick. And the more of those, that's what will be the roadblocks for that virus to propagate in the population. Because you are immune to it, I will be in your face, even if you have an active disease, but I'm immune to it. So I will minimize its spreading out across one person to the other, etc. And again, as we just, for those who are listening to us the first time, we touched base on how that disease travels is by droplets. And that's why that 6 feet, which came from apparently previous studies, that's a safe distance where those droplets are far enough from one person to another. So distancing and distancing and distancing, even though nowadays some areas, actually the 2 states of Sergey and Jessica, they may tell us some more about it later on. Florida and Georgia are heading out to some opening up gradually next week. So they have probably more information about their readiness and so on.
Thank you, Doctor. And Jessica, I'll move back to you to maybe add some more comments if you have any. And then also, if you could answer the next question, to your knowledge, what is the current timeline for a vaccine?
Oh gosh, that can take years. I think record for a vaccine development, which was pretty sporadic, or which was escalated, was around 4 years. I remember reading about that not too long ago. So I don't know. I would definitely over a year for an actual vaccine. I think, like I mentioned, the record was 4 years. But as far as that, whenever they were determining SARS and MERS, seeing potential for vaccines, that would be something that kind of helped escalate that process. But again, we're not going to see a vaccine for a while. So I think with serology and widespread testing, that's going to help us know currently who has maybe had it. The other thing is infection doesn't always equal immunity. And so this is a very new virus. And so what I find very interesting is, as we're doing serology testing, in the past, we've never used antibody tests for respiratory viruses to determine immunity. So unless this is along the line, something like varicella or even measles or mumps, that to determine immunity, we just need a lot more information on that. So that's all I really have to add on that piece.
Thank you, Jessica.
And I thought, Jessica, you will have the inside scoop. You're driving from Emory Hospital down on Clifton Road. You can get some inside scoop from the CDC. What's going on with that vaccine?
What's going on with that?
If they let you go through the gates.
Yeah, no, not yet. But I think it's very interesting, and there are studies that are obviously occurring. We have to test with animals first, and we have to make sure like this is still FDA approved. We still have to go to through the channels to ensure that it is safe for humans. So
thank you, Jessica. Dr. Sergey, would you have anything to add on a timeline for the vaccine based on anything you've heard?
Well, I've heard there are 100 candidates and maybe 3 or 4 that are more in active development. Just understand that the vaccine development is not a linear process, and it does have its pathway, but specifically for coronavirus, there's a component of immune activation. So you have to be very careful, which you sometimes see with the dengue vaccine, which sometimes makes the infection worse rather than protecting you against that. So this is a not straightforward approach. And although we're hoping to get something in a year and a half, but there could be some kinks in that road. So you really have to be careful. There are historical examples of vaccines being detrimental. So you really want to have good testing, go through the phases before you really release it to the public. So that will take time.
Mhm.
Thank you, Dr. Sergey, very much. I'm going to go to you, Dr. Fadi, for this next question. Do you think that the fall will bring a resurgence as they are beginning to suspect? How are we going to know the difference between the flu and COVID-19? Dr. Fadi, if you could start.
Boy, that's the million-dollar question. I don't know if anybody knows actually. If we're following, and I'm not a virologist, but we follow the flu quite closely from a pulmonary standpoint, and I start giving the vaccine as early for my chronic lung patients, the COPD, etc., because they're very susceptible to the usual, common cold and the flu, of course, early September. So that's where the talks about this resurgence, and I could see between the media and the news and the social circuits, this is the hot topic of the day. Is there going to be a second resurgence? Like we heard from the colleagues already, the issue of the vaccine itself. I mean, you're hearing Dr. Fauci, etc. Optimistically, he talks about a year to a year and a half. But doing it right, and it takes longer than this in the world of medicine. I mean, you got to do the right testing and the randomized studies, etc. But as far as to the question, if you want to move those two in parallel in terms of comparison, that is the flu, which at least we have the historical information about it. You start in September, and then you continue administering the vaccine as late as till February, beginning March, but it dies down the early fall, the spring and the summertime by nature, by immunity. In here, we are still debating the testing part until we figure out an easy way. Hopefully the saliva kicks in, becomes national, easy to acquire the machine, the testing, the kits, all of those hurdles that we are hearing about it from one region to another being not so uniform, then I don't think we can make that estimation. We need to turn down that curve to a non-scary peaks anymore of this initial wave, and then hopefully the summertime has some its effect on between the heat and the etc. has a more of a killing effect on the virus, and by then we're hoping that we have tested enough people, we have tested the immunity part, the antibodies, the IgM, IgG told us who was asymptomatic and got immunity, then we will have a better understanding as to the penetrance, etc. And then I think, and I'm not a public health or a virologist, etc., but these are the models that you need to go by. I don't know if Jessica, you have something more to say. You're close to the CDC and you're hearing probably things more readily than we are.
Yes, Jessica, please, if you would comment on what maybe you have heard and about the possible resurgence in the fall.
Yeah, so I mean, I think it's something where to determine if we are going to be more prepared for a resurgence in the fall. I think really looking at if, with social distancing, as we start ramping up and getting businesses back in order, that was definitely a concern. And are we going to see a resurgence because of all the people that were avoiding the hospitals, avoiding, they were staying home, they were avoiding hospitals, they were avoiding going out in public. And so it's definitely a possibility and something to prepare for. You prepare for the worst and hope for the best in that sense. But there was I saw a tweet the other day, and you have your current wave, right? Your first wave of these are COVID positive patients, and then your second wave, could it be all of those that are staying home, you know, not getting maybe urgent care because they don't need it at that time, but it's escalating on to, they may have like graft versus host disease that has escalated to like a grade 3 or 4 because they're avoiding procedures, they're avoiding going to the hospital or getting that care that they need. So, you know, as things start ramping up, it's something we're preparing for, but you don't know. So just something to keep on watch.
Thank you, Jessica. Great response. Dr. Sergey, I was hoping you could comment on the second part of that question. If you maybe know a little bit more about how we can tell the difference between COVID-19 and the flu, if there does happen to be a resurgence this fall.
I mean, the short answer, I don't think we really know. I think we're learning, and we really not even done with this current wave yet. To really, I mean, we have to be concerned about currently what's happening. We have to be slow in the way we reopen our. Of course, everyone wants to go back, but I think it needs to be done in stages to really understand the behavior of the virus. We may have built up the immunity in our population, which we may not be fully appreciating. That may or may not be there. If it's there, it may change the behavior of the virus, and it may be protective from further spread. So I think population studies of antibodies will be helpful to get some understanding of the dynamics of the virus, and the modeling may be adjusted to that. So I think the next couple of months will really be telling. You know, I would not, you know, I'm more concerned about what's happening now in the next couple of months before I start getting concerned about the fall. And to see how we are going to be able to, because people have been anxious, they will stop doing social distancing, and we're going to have to see how that's is it going to backfire or no. So I think that will tell us more to be prepared for the fall. I mean, the virus, as far as temperature goes, everyone has been hoping that maybe it's temperature dependent. So far, it doesn't seem to be. So I think we have to rely more on the social distancing and on the buildup of the community immunity in population as our protection against further advancement of the virus. So I mean, as far as the fall, I don't think I can tell you what, you know, I just don't know what will happen.
Thank you, Dr. Sergey. I'm going to move on to our next question, and I'm selfishly going to include a question of my own with this question, since I didn't get to ask a question the last session. There were so many submitted. I'm going to start with you, Dr. Fadi, on this one. This is from Deacon James. What advice can you give to our parishes and to us individually as the shelter-at-home restrictions are lifted over the next few weeks? And then my question that I wanted to combine is, over the last few weeks, we've seen a lot of changes with what has been recommended or not recommended. And I was wondering on your perspective, Dr. Fadi, on using masks. I myself have been using masks going into the store when I have to, and was wondering if your position on this had changed since the last recording, Dr. Fadi. Dr. Fadi,
I thought he left the meeting. I saw the note that
he did?
I'm not sure what, I just saw a little note there.
Okay, no problem. I will maybe just shift back to you, Dr. Sergey, if you could, from your point of view, just say, again, what you can advise to our parishes and to us individually as the shelter-at-home restrictions are lifted.
Well, I mean, the last recommendation from CDC that I heard is to wear some sort of a mask, like a cloth mask, when you are expecting to be in a crowded environment. I don't think it makes sense to wear a mask when you're walking in a park with not people around. But if you're out in the grocery store and people are shopping around you, last I saw from CDC is to wear a cloth mask, which is dense enough that it doesn't let the light through. It does not need to be a medical mask. And again, the masks are not so much to protect you, is to more protect people from you. And if everyone's wearing the mask, then we're doing a mutual effort to stop the virus from spreading. So I think we should continue doing that. Jessica, have you heard anything updated from the CDC in that regard?
Yeah, definitely. So especially like our messaging here at Emory, as you mentioned, I wear a mask to protect you and you wear a mask to protect me. And it's basically an effort to escalate or basically increase social distancing when in public or those moments that you can't. So, I see people driving around in a car by themselves with their mask. That's probably not necessary. But, when you are in public or you are with somebody else that um, you want to make sure that you are protecting them. They're not your direct household and so forth. I would definitely wear a mask. And it is much different than what we did talk about initially in our first Zoom meeting. So, as far as the cloth mask versus our procedural masks, we do want to save the procedural and surgical masks for those in the hospital, but it's definitely appropriate to wear a cloth mask. I actually have a new one right now, so to wear whenever I go outside. So, in work and different areas that social distancing isn't really feasible, I would recommend doing that as well.
Thank you. Thank you, Jessica. Although we did lose Dr. Fadi, we've gained Dr. Gregory, and it looks like you're with us now. Dr. Gregory, would you mind introducing yourself, where you're from, and your field?
Hi, my name is Dr. Greg Esber. I'm the Associate Chief Medical Officer for Emory Healthcare. I'm our Medical Director for Telehealth, and I'm a neurologist, and I've been at Emory for 15 years.
Thank you, Doctor. I wanted you to have a chance to respond to the question that we just were responding to. What advice can you give to our parishes and to us individually as the shelter-at-home restrictions are lifted over the next few weeks?
Well, it's interesting. I came into the last part of what Jessica said, and generally speaking, I wind up deferring to our infection preventionists because they know the most. They know more than the doctors do because of how they're living right now. But here is what I would say. We are not out of the woods. We recognize that in past viral infection seasons, specifically H1N1 in 2009, that the loosening of social distancing restrictions can result in an increase in cases and case number, which functionally would be a second peak. So now that we've been successful in flattening the curve, which is to reduce the total number of cases so as to not overwhelm the health system, we have been successful. We have been successful in Georgia. Many other states have been successful. However, we must take caution because as we loosen the restrictions, and there are some states that are being more aggressive about that than others, we are in one of those states. We have to be very careful because as we go out, as we potentially, whether or not we're donning our mask, whether or not we're washing our hands, using hand sanitizer, etc., we could see a second peak happen, and we might be right back where we were when the first peak happened. Because we don't know what the herd immunity looks like. In other words, we don't know what immunity has taken place amongst a lot of different people who haven't been documented as infected. We don't know what that looks like. We're going to learn. We're going to learn because we have antibody testing that's becoming available now. In fact, one of the reasons I was late is because I was at Emory getting my antibody test right now. All healthcare workers at Emory are supposed to be getting our antibody tests. But what I would say for our parishes specifically as they look to reopen, what is critical is that we must follow social distancing protocols. People must be masked. There should be ample hand sanitizer available. People must say stay 6 feet apart. I would not advocate for any fellowship hour where people are drinking coffee together from the same carafe. Everybody coming and putting their hand on the carafe and, you know, getting coffee and then going and talking and sitting at a table within 6 feet of one another. In fact, our chief medical officer this morning said that he is very concerned about eating places, places where people join together to eat, because that is potentially where you might see droplet spread. That's potentially where you might see droplet get on a table with coronavirus present. People are touching the table, etc. So I would advocate that if churches are going to reopen in a state, that strict social distancing protocols be observed, and that we still ask our elderly to refrain from coming until we are far past the tail end, and that frankly the younger members of the parish or what have you think about their elderly colleagues in the parish, and that they serve them in other ways to make sure that they maintain touch within within our community. And I'll stop there and respond to any additional questions.
Thank you, Dr. Greg. I'll go back to you for this next question. What kind of side effects have you seen from the virus? In which way does it affect the brain? What other systems and organs are affected?
So, so there have been case reports of encephalitis, which enkephali in Greek means the brain, and itis is inflammation. So encephalitis means inflammation of the brain. In fact, we had a case at Emory where a patient died from the central nervous system encephalitis that she contracted during a COVID infection. There have been case reports of encephalitis that have occurred, and there have been some reports of increased clotting that potentially can make stroke more apparent. However, that being said, the number of stroke cases that we are actually seeing certainly in our environment, in our major comprehensive stroke centers, is actually reduced compared to that which we were seeing before. Now that's the neurological picture of what can happen with COVID-19. I'm sure everyone is aware that the major symptoms of COVID-19 are fever and cough, diarrhea in some cases, malaise, which is the feeling of fatigue and being weary. Another specific neuromuscular symptom is myalgia, which is muscle pain. And people may be familiar with this as what happens in muscle pain is the feeling of pain in the back and pain in the legs that you get when you have a flu-like illness. Those are myalgias, and that is the presence of the virus causing some pain in the muscles. Two very specific complaints are anosmia or dysosmia, which is when the virus actually affects the first cranial nerve, which causes someone to not be able to smell. And so people knew that something was wrong when all of a sudden they were unable to smell, whereas somebody in the same room was able to smell perfectly. And they would say, "Do you smell that?" And another person would say, "No, I don't smell anything." And in up to 2/3 of cases, anosmia or dysosmia, which is the lack of smell, was the herald. It was the sign of a coronavirus infection. And specifically when people have anosmia or dysosmia, their taste may also be affected. So because it's the smell, the first cranial nerve that gives you smell that actually helps you taste food. So those are very subtle symptoms that aren't really appreciated by the masses that can actually be heralds of COVID-19 infection.
Thank you, Doctor. We've had a couple more questions come across, and I'd like to start with Jessica on this next one and then go to you, Dr. Sergey. The question is, this is coming from Nikki, someone who works in the dental industry. there does not seem to be one overall test that is completely effective. For us in dental care, we have been told to stay closed until further notice. Do you have recommendations on how we can return to work and under what conditions? We know we're having to work under the worst kind of situations, being up close and personal with every patient. Thank you. Jessica, if you could start.
This has come up actually with, hairstylists and other industries that are starting to open for business. What we're doing even for our ENT folks is really just recommending, as things start going back into business, that we're recommending that they're using proper PPE. So, my mask protects your mask protects me. Obviously in the dental office that can't occur with the patient, but we would definitely recommend that you guys are utilizing face shields. You're wearing procedural mask as well, and that can definitely help with the droplets, just protection for your staff. So I wear face shield to protect that mask. That will help you. And then frequent hand hygiene. So we want to make sure that that's obviously part of your practice.
Thank you, Jessica. Anything to add on that one, Dr. Sergey?
Yes, I mean, I agree with that. I think you have to wear the mask. If patient is not symptomatic, it's not likely they will have it, but it's possible. But I think you have to do the precautions the best you can with the masks. I mean, N95 is the best. Would be the best. I'm not sure if to the point of recommending that to dentists, but it's something to consider if you're having some invasive procedure or if you're concerned about a patient having something. If you can use a 95 as a dentist, that will give you the best protection for yourself.
Thank you, Dr. Sergey. Dr. Fadi, it looks like we have you back again.
I'm so sorry. Yeah, now I'm charging through the wall, so I'm sure.
No problem. Dr. Fadi, I think it's probably because I asked a question and my question was bound and determined to be answered. So I'm going to ask you again because I'm so determined.
Let's give it a shot this time. Yeah.
My question was related to the one that was asked earlier. Mine had to do with masks. And I know you talked a lot about masks in our last session in the first part. And, we've heard a lot of things about recommendations on the news about whether or not we should wear them. I've heard recently that now we're being told we should wear masks. As a pulmonologist, I was hoping you would speak to that. And then any other comments you have on the question earlier that was asked about what advice can you give our parishes and to us individually as the shelter at home restrictions are lifted over the next few weeks?
Right. So as far as the mask, you can tell I have the N95 that I keep it. I've been with the shortage for a little bit, but they rationed it to us as a professionals at the hospital. But we never ran out of it. On top of another layer that I'm using, that is not the case with the general population. Of course, with my specialty and having to take care of some of the COVID patient. Let's go back to the fundamentals, and I think all the other participants have covered it. The transmission is droplet based. So if I'm talking right now, it's if I'm sneezing, coughing, etc., the risk of dropping around me or further up to 6 feet is there. So this is how the disease transmission starts. It makes common sense that you want to limit that. From as little as the little fancy mask that Jessica showed, and that communities, when they ran down on the PPE and it was all over in the news, we started sewing them at the house, etc. All the way to this is like a respirator mask. Basically, ideally, when you test for those masks, you gotta do a inhalation test, not to divert from the subject, to make sure you are not seeping anywhere else. Of course, we're not doing that nowadays. As long as you have an N95, and for double protection, you're adding a surgical mask. And of course, with the surgical, to protect yourself, because you don't want to go on the face, on the cheeks, and the eyes, and this is how you get it yourself. So first order of business, like it has been mentioned, from the communities all the way to the professionals, you gotta, the more careful you are, it doesn't hurt. As we are talking and repeating ourselves in this discussion, we are learning this disease, this enemy. We know a little bit about its propagation. We are still trying to define the disease, like I mentioned in the first part. And in this regard, Dr. Esber was not there, but I want to go back to him being a neurologist to ask him if he's seeing this form of encephalopathy in those who are surviving it in the hospital. But back to the mask, as the states, and they are from Florida and Georgia, the two states that are about to release those restrictions, I think it makes the emphasis of its importance to emphasize those short of a vaccine, short of an adequate treatment, and short of the immunity and the penetrance of this disease, as it has been said. And I'm glad to know that in my previous alma mater at Emory, now they're doing the antibody. I don't think over here in Lafayette we have gotten it yet, but this is very important. Like we mentioned it a couple of times, you gotta know if you have been immune and you were not sick, and that's what we call the asymptomatic carriers. Now, like I think it has been mentioned, we don't do serologic. I don't send you to the lab to draw blood from your vein from the antecubital here to do a test for the flu. I mean, this is I do some serologic testing for some infections in certain lung disease, but this is a single patient. Maybe you have a handful of those that you are doing this, and you do serologic testing for the strep, etc. In the flu, because it's a mass, it's a public health issue, we don't do serologic testing. You give the vaccine nowadays. I mean, you give the shot. In this disease, in the coronavirus, although we are following it from a public health standpoint along the influenza-like illnesses in terms of the curves and the public health models, etc., but the disease is different. In the flu, you get the body ache, the feeling like hell that you don't want to leave the house, your muscle ache. 2 days you stay home by yourself, drink soups and tea, etc., and you're over it. And there is actually an antiviral for it, a 5-day course, antiviral, Tamiflu. But in here, as we are, like we talked about it in the first session, it's different. It's involving the lungs. Now we're involving other organ system. I think the rate of kidney involvement and this cytokine surge syndrome, the dilemma with how we treat them on the ventilator. A month ago, I think we were probably more informed than I can tell you than now. What was almost science in terms of how to ventilate those patients on the ventilator a month ago from that ARDS standpoint, because it took years and years of science and trials to know a certain way of treating the ventilator and make an impact on them. It does not seem to be the case here and there. Again, there is a differentiation in the area and whom you listen to, that it may do the same thing with the COVID respiratory failure. Again, I don't want to dilute the conversation here for the audience, but what I'm trying to say, there is a lot of unknowns. Meanwhile, while we are trying to flatten the curve to go back to normalcy, and by normalcy, I know people want to go to a restaurant, but I don't know if you're going to go to a restaurant with a mask on, but until we know for sure each community and each district and each local health authority has a good handle on what they have, the rate of penetrance, the immunity, and the daily occurrence of new cases, then you gotta be on the safe side. And yes, use a mask on your way out. Now, as far as the parishes, first of all, Christ is risen. We can say it here publicly. We just had our Easter. If any, Sayyidna can tell you, I'm a chanter, so no one was more miserable than missing the whole Holy Week and staying home. But yeah, I mean, by no means churches right now and social hours and so on. I don't know. I think region by region, it needs to be looked at, and it's probably at a later stage that the religious congregation can have a role to start opening. Although people are hungry to go back to services, I'm pretty sure.
Thank you, Dr. Fadi. Dr. Greg, I want to thank you for being so responsive in chat. You've answered several questions, and I was hoping that you could maybe summarize the responses to a couple of them. First of all, there was a question clarifying what elderly means in terms of age. Not everyone, I think, can read the chat, so if you can just briefly respond to that. And then Bishop Nicholas asked, what does 95 mean in N95 and then N99, Dr. Greg?
We typically consider elderly to be age 65 or over. But as I said in the chat, every 65-year-old is not considered equal to another 65-year-old. There are old 65-year-olds and younger 65-year-olds, and that often is based on the presence of chronic disease that certain 65-year-olds may have compared to others, a history of smoking, a history of alcohol intake, a history of prior illness that has given folks underlying conditions or comorbidities. But in general, we say that 65 is considered elderly, the age of Medicare, basically.
Got it. And then you also had responded to the N95 versus N99, if you could briefly summarize.
So basically, the N95 versus the N99, it refers to the percent of particles that are filtered. So an N99 filters 99% of particles, and an N95 filters 95% of aerosolized particles. So theoretically, the N99 is better, but in healthcare, the N95 is the standard. Now in healthcare, what's required is that we are fit for the N95, because you can imagine that one could be wearing a mask and it's not fit appropriately, and that fit will, if it's not fit appropriately, aerosolized droplets can bypass the mask. And so for healthcare workers, it's very important that we who are subject to the aerosolization of particles, that we be fit appropriately.
Got it. Thank you. Thank you, Dr. Greg. Dr. Sergey, I wanted to ask you this next question, if you would start. What is the medical opinion about taking communion from a common spoon? Dr. Sergey, if you would start.
It's a tough one. I mean, I've been fielding this question for the past month for two dioceses, Antiochian and then Russian up in the Midwest. I don't know. I mean, there are no studies. It's a tough call. It's a question that borders the science and the faith, you know, to be honest with you. I mean, you know, I would be, as an Orthodox Christian, I've been refraining answering this question. When I was asked this on the conference call from the Russian Midwestern diocese, I basically deferred to the priests. I mean, I told them there are no studies, but you know, it is what it is. I mean, what can I tell you? I mean, I don't want to speak wearing a white coat about this, to be honest with you. I mean, what can I tell you?
Understood. Yeah, we will ask Bishop Nicholas to comment at the end. We still have a few minutes, and I know he'll have a good response. There was another question for Bishop Nicholas as well, but I want to focus just on our medical staff while we have you. I want to be respectful of your time since we just have a couple of minutes left. I don't know
Can I say something quickly?
Please do, Dr. Greg.
We are physicians. We are medical professionals, but we are also Orthodox Christians. And from a science and faith, you know, I agree with Dr. Sergey that scientifically, you know, it is hard to say that, oh, because we have a metal cup, and oh, because we have alcohol, and oh, because we have hot water, we're not going to be infected. But we as medical professionals still have spirituality and still have faith, and we must, and for my part in particular, will say that we must believe that the communion is what it is, which is the body and blood of Christ, and it is a matter that jumps over science. And what I will say is that is that for we who believe, and Sayedna will say this, but for we who believe, we should be strong in our faith. And as we proclaim Christ is risen, that we partake of the sacred cup and the sacred communion with the greatest faith, the greatest strength, knowing that it is the healing power of Christ that will be with us.
Thank you, Dr. Greg. That was so well said, and we're actually at time right now. I again want to be respectful of your time schedules, and there were a couple of questions for Bishop Nicholas, so I first just again want to thank you all.
Mike, just while Dr. Esber is there, I don't know if you heard me, but as a neurologist, Greg, have you been noticing a certain degree of encephalopathy in those who make it out? Have you been?
It's rare, but it does happen. We've seen cases at Emory. One patient died from it. Yeah. And so we are seeing it. It's uncommon though. It is uncommon. And it is typically you would, and we can talk. I'll put my cell phone number in the chat and you can text me. And then we could talk more about it.
It's just a clinical observation that I've been experiencing, that it is not only their respiratory status, they're acting not right.
Yes, they have encephalopathy, they're disoriented, and they have other signs and symptoms, including some of the other neurological conditions that we stated. So yes.
Our pathology team is also looking at this from following death, see if there's any sort of neurological degenerative disease. So it'll be interesting to see if there's any long-term effects on this.
Okay, we had one last question that snuck in. I'd like to end this after this question so that you all can get back to work. But it looks like there's a question from Sarah Hodges. What kidney problems have surfaced as a result of COVID-19? I'll just open it up if any of you know.
We're basically seeing acute renal failure with multi-organ damage. And so many of the patients that are in the ICU that are intubated are receiving continuous renal replacement therapy, which is basically dialysis. And for those that don't have those resources, there are different types of dialysis that can be administered.
Got it. All right, well, thank you to the panel, Dr. Fadi Malek, Jessica Tarabay, Dr. Sergey Akimov, and Dr. Greg Esber. Thank you all very much for joining this panel. Christ is risen.
Indeed is risen.
He's risen.
And I am going to just say that all of you, we're praying for you. And thank you all for what you're doing. You're on the front lines. We're definitely all praying for you. And I wish you a very blessed rest of this bright week. I do have a couple of follow-ups for Bishop Nicholas, but since you're all so busy, feel free to jump off, and then I'll just have Bishop Nicholas answer a couple of quick questions.
Thank you, guys.
Thank you, Mike.
Thank you.
Sorry for technical interruptions.
No problem at all. And then Bishop. Okay, thanks.
Thank you, everyone. Thank you. God bless you. We're praying for all of you as first responders in this pandemic. God bless you all.
Thank you.
Thank you.
Now, Sayedna, there were a couple of questions that one was for you directly, but if you could first answer the question about the concern about receiving Holy Communion and the spread of the virus.
Sure. About a month and a half ago, I sent an email to the diocese regarding communion. Communion is the body and blood of Christ, and it is impossible for it to hurt us, to communicate diseases to us, because it is a healing presence of our Lord. This is our faith. This is what we should believe in. But if we don't believe in that, then we have to look at the practical practical end of it. The first person who should be violently sick every week is the priest or the deacon who consume the chalice at the end. After everybody receives communion, what is left over in the chalice is consumed by either the priest or the deacon. And if there is viruses or germs or anything of that nature in the chalice, then the first people who get sick on a weekly basis is the priest and the deacon. So it is impossible for it to hurt us with respect to germs and viruses. The second part, which is practical, Dr. Greg referred to it, is that the chalice is made of either or gold-plated or silver-plated. And gold and silver have the property of killing germs. There are some medications that's like ointment that you can apply to your skin if you have an ulcer on your skin or you have an open wound area. And that medication called, for example, Silverdine, and the main ingredient of that medication that kills bacteria and viruses is silver. And I attest to that personally. I had to use it a few months ago. I had a problem in one area of my skin because I used a Band-Aid that has latex in it, and it burnt my skin. So the doctor prescribed Silverdine, which is a prescription broad-spectrum medication, and that killed any bacteria that was on that area. Added to that, as Dr. Greg mentioned, the hot water and the wine that has alcohol. So from the faith perspective, it cannot hurt us. And from the practical point of view, the silver, the gold, the hot water, the alcohol will take care of the problem as well, if we don't want to believe from the faith point of view.
Thank you, Sayedna. There was a question for you directly, and this question was, Sayedna, how would you recommend large parishes do social distancing during services? I'm assuming this is as states begin to open back up and as we receive direction that we can start attending service again. How would you recommend we do social distancing in large parishes?
Well, we have to adhere to the civil authorities' recommendations. They say a minimum of 6 feet among people. I say, personally, I don't think that's enough, especially because of micro droplets. Micro droplets can travel everywhere. So at the very least, we have to stay 6 feet from each other. In my personal opinion, I would stay farther than 6 feet. But this is not the time to do this, because the Metropolitan has sent a directive to the Archdiocese that churches are closed for now, and the maximum number of people in services cannot be more than 5.
Thank you, Bishop Nicholas. And we're now concluded. If there's anything you would like to say in conclusion before we do end the Zoom meeting, please share with us.
Absolutely. I would like to thank the medical staff who took an hour of their very, very busy time at this pandemic. They are overloaded and overwhelmed with patients and with treating all of these patients. So I'd like to thank them on behalf of the diocese, on behalf of all the parishioners and the clergy for doing this for the second time. And I'd like to thank you, Michael, for moderating this as well.
It's
Yeah, thank you, Edna. Thank you, Michael. Thank you, everybody.
Thank you, Dr.
Be safe.
Thanks be to God. It's my pleasure. And I just wanted to remind everyone that I will be I'll be doing some editing and posting this video to the DOMSE YouTube channel, and we will be sharing the link in our band group for DOMSE, as well as on the DOMSE Facebook page, so stay tuned for that. Again, thank you all for joining. Have a great rest of the week. Christ is risen.
Indeed, it is.
Truly.